SARS-CoV-2, commonly known as the coronavirus, has brought a spotlight on the importance of social distancing to possibly curb the potential massive demand on the healthcare system. To serve the public interest, physicians are forced to try and rapidly adopt telemedicine. Although telemedicine itself is easy to implement, getting paid for such services is anything but simple. I am very grateful that Mark Painter from PRSnetwork is with us today to help guide us through this confusing issue. So thank you so much, Mark, for coming on the program.
Thanks for having me, John. It's definitely a scramble right now as everything's changing so quickly.
Okay, I'm going to quickly define the scope of our discussion. We're going to concentrate on the E&M type services for telemedicine and not on remote patient monitoring or chronic care management. So that's just because it's such a big topic as it is, just concentrating on E&M services.
I think that's more relevant to and easier to actually spin up and to actually meet the needs of what we need. So I agree that'll be good to keep it to those two.
I'm sure you've gotten a lot of people calling you on trying to set this up. What are some of the things that are most pressing that you've heard from some of your clients?
So I think everybody's worried about a number of things across the board. One, how do they handle their patient safety? I think is key. How do they continue to serve their patients, especially with a number of states now pushing for all elective surgeries to be postponed? How do they stay in touch with their patients? All of those things are big, and they primarily surround patient safety. And then, obviously the secondary concern is, how am I going to weather this storm financially? Which is also a legitimate concern. I think everybody has that. I mean, it's not unique to medicine. We've got restaurants and bars in the same situation. So it's a bit of a juggle of both of those things. And I think, my blanket number one statement across the board is, everybody needs to figure out where their capacities lie, what they physically can do, and then what they're also covered for. So one of the first steps that I've been directing a lot of folks to take is pause for a minute and check your malpractice insurance coverage for telemedicine.
Okay, so there are typically two big aspects. One is legal, and the other is reimbursement. So, all right, we'll jump into legal real quick. Definitely, the first place you want to call is your medical malpractice insurance. I contacted them recently in anticipation of telemedicine before COVID-19. And there are certainly a lot of issues that needs to be covered. One of them being interstate practicing. Does your coverage allow you to practice interstate? Meaning, I have a license to practice in Arizona and Missouri. Can I see a patient who is physically in California via telemedicine? And will my medical malpractice cover me? That's one of the big issues.
Correct. Yeah, it is. I mean, the licensing within each state may vary. Your malpractice may vary. So checking there would be a good first start. I mean, I don't think you or I are capable of actually giving the full picture of where all this lies with the malpractice. And that's why I recommend right off the bat, get to your med malpractice carrier and find out what you can and can't do.
Right. And also, if you have to prescribe or refill a medication in a different state while the patient is traveling somewhere else, then how do you, that the patient is most likely in another state. So that's one way for payers and lawyers, I guess, your plaintiff's attorneys to say, well, you knew that the patient's in a different state. I mean, some of the things that nobody ever thought of beyond coding and billing. And also, how do you verify where that patient is actually located? So those are some of the concerns that I have, other than just asking the patient, okay, are you in Arizona in my case, or are you in Missouri? The other thing is consent. How do you consent the patient? I guess verbal is the only thing that you can do when it comes to telemedicine.
So, and luckily that's enough in most cases. I mean, I think you remember from some of the recent seminars that you participated in with me that we have gone back and forth with a particular payer in regard to informed consent as an audit. And the reality is there are only certain places that require signed informed consent. and those are actually more JCO and locations, and that would be ambulatory surgical centers, hospitals. Even in the office setting, you don't have to have informed consent for a lot of what you do. But the key aspect of informed consent is that the patient clearly demonstrates understanding of what is happening and that they're willing to participate in the care. And you need to document that in the medical record. So you do want to have that clearly documented in the medical record at the very least. But taking a look at what you can and can't do with writing to protect you. We know this is a litigious society. We hope that even the lawyers have a little compassion during COVID. We'll see. But protecting yourself is smart there. So at least get the informed consent documented in the record. And you ought to explore what you can do in the written format with your patient portal and those types of things.
And one of the things that you had mentioned when we discussed this earlier was maybe exploring something via DocuSign if you want to go that route, so that you can at least get some sort of a digital consent. All right, let's switch gears real quick.
John, actually, one other thing I want to talk about just briefly on that is the informed consent to treat is one thing. The ability to charge somebody, your finance documents and your financial policies, and your HIPAA issues are things that you definitely need signatures for. So, if you may have that in place with some of your established patients, but now as we expand to maybe new patients coming your way, you've got some other things that you do have to consider in that. And that's why I definitely, focused on potentially DocuSign or looking at some other areas. So,
yeah, so there are two different, I think, I think initially Medicare, at least, they intended telemedicine to be mostly for established patients. Some of the codes are patient initiated and things like that. So they're meant for established patients. But you are absolutely correct. A lot of the other consents that we obtain from the patients, you should consider getting a physical signature or digital signature, like you mentioned. Let's switch gears real quick. I know a lot of politicians and states have verbally said or have written policies now about coverage for telemedicine visits in light of COVID-19. I know Colorado has something already implemented. Is that correct?
Yeah, the governor here actually ordered insurance companies to waive copays for telehealth visits. And we do have on the books a telehealth parity law. So essentially, if you bill a 99213 from the office, or you bill a 99213 as a telehealth service, both are required to be paid at the same amount under Colorado law. And a lot of states, in fact, 36 of them have that parity law in place. I am willing to bet that you're going to see a number of those waivers ordered by the governors across the states, as everybody's really watching how everyone else is doing things, and they're reacting locally, so maybe a little bit slower, but in the end, it does seem like they're all kind of coalescing around specific strategies, and one of them is expanding telehealth, which makes a lot of sense.
Hopefully it's going to be in a good way, like the contagion mentality that we are seeing with the toilet paper and the water, which does not make sense. But hopefully the governors will behave in a similar manner, in a contagion mentality, to adopt the rapid implementation of telemedicine as far as payment and parity. Because I want to emphasize that just because some politician says that it will be covered, or just even if it's in writing, it doesn't mean that you are actually going to get payment. And also, if you do actually get payment, it may be greatly delayed. So I'm very, very enthusiastic and happy that they are covering, but just because they say it will, as we know, anything through the government is kind of iffy.
Well, what you're really bringing up, and it's a great point, is there is a two-step process in all of this stuff, right? So one is policy and the other is implementation. So, ultimately a policy can go out that says you have to pay for telehealth services without a copay from the governor. But the implementation for the payers, may be that, okay, we're going to follow this policy, but our interpretation of this policy is you still have to have live video, audio, and HIPAA compliant, synchronized exchange. They may or may not require. I think most of them don't require you to be in an approved facility, except for Medicare. But they may have restrictions as to how many times you can have a telemedicine service. And it may not be specialty specific, so they may burn it up in one or the other. So, checking with the payers as far as what implementation is there is key, and that's a very good point. It's just a policy is very different from the practical implementation.
Boy, so much to unpack there. So there are, well, depending on the type of telemedicine, I guess we'll go into that in a second. There are different originating site and distant site requirements. Those are Medicare's terminology. So you have to make sure that you understand what they are per payer. And like you said, policy does not actually mean actual payment, and implementation is going to be a totally different matter when it comes to state level. And also, just like Medicare, right? Medicare, you have multiple Medicare administrative contractors depending on the region in which you live. So the MACs can interpret Medicare rules differently among the MACs, which is kind of crazy.
It is kind of crazy. And then I think the other thing is probably everybody's probably aware by now that we had the emergency legislation that was enacted recently. And, we've been checking back and forth, and there are some websites to monitor that you do want to jump into and start looking at. But, that the way the coverage came out on that is it kind of opened up health telemedicine across the board for Medicare. And really it did, but only really as a door open. And so what they did do overall was encourage physicians to be a little more proactive, to encourage patients to generate visits that would fit with under the existing codes, which I know we're going to go over in a minute. But it did not change the base regulations of where a patient has to be, originating site, and all those. It did give the Secretary of Health and Human Services the ability to declare an emergency by area. And there are ways for states to petition to become emergency areas and obtain coverage, which I'm sure is happening right now. But as of yesterday afternoon, there had been no emergency areas declared. So those are things that we're going to have to watch. It's just that evolving situation of this might happen, but it's not happening yet, and you got to wait for the full trigger to come in.
Oh gosh, I was going to say something. Anyway, it skipped my mind. A lot of people have asked, what are some? I'm going to jump ahead a little bit. A lot of people have asked, what are some of the platforms that you have seen or heard implemented by physicians when it comes to telemedicine?
So I think you mentioned a few as well. Chiron is probably the one I have the most experience with. There are a number of your electronic medical record companies that have basically plug-in modules or add-on modules that are fairly easy to turn on and allow you to do stuff. We're exploring, there's a going kind of far afield. Microsoft Skype for Business. You can actually get a BAA with Microsoft to do that, and that, of course, could work from a HIPAA secure standpoint. So there were a couple of folks that have dabbled in that one, but that requires actually your patients to have a Skype for Business account as well, which is an expense for them. So I don't see that one catching on as well. And then we're exploring things like WhatsApp and some of those things. And you mentioned a couple of different ones that you've seen. You can add those to the list.
American Well is another one. Chiron Health, as you mentioned, and doxy.me, doxy.me. And last one that I have quickly written down here is your built-in electronic health records. Most likely has a platform or two, actually, regarding telemedicine and which ones you can use. Dr. Gabal asked regarding insurance, does that mean the insurer pays the copay, or does the provider lose that amount when it comes to telemedicine?
From the Colorado perspective, the healthcare and the insurance is supposed to pay the copay. So essentially, they're waiving the copay doesn't mean that nobody gets it. It just means the insurance company is supposed to get it. That was the intention of that rule. But as John, you mentioned earlier, the actual processing of that is something that the insurance company may not have programmed in. So I will not be surprised if everybody gets paid minus the copay and then you have to go back and get it, or you pick the copay up later. So, but the intention is that the insurers pay the copay.
Got it. Yeah, we'll see. I mean, I can just see it now. You submit the claim. Is the insurance companies processing software sophisticated enough and already programmed to indicate that from this date to that date, for the date of for those days of service with a place of service of 02 or using a GT or a 95 modifier, then those visits are going to be paid the full amount, including the copay by the insurance company. I mean, there's no way. I don't think that's going to be happening anytime soon. It's going to be a delayed thing, and practices will have to appeal most likely.
Yeah, I mean, just keep track of those things and figure out what you can and can't do. And I mean, those are things that you're going to have to watch each payer to find out what's covered, what's not. I mean, contacting your payers, finding out how they're going to process them, and of course, they're going to be deluged with phone calls asking the same question from docs and patients. So it may take some time doing some research on their websites, sitting on the phone and battling through that. And I really think, one of the things that we're going to try and do is, like you've done, John, is, wiki knowledge. Everybody needs to really share across what they're learning in different states, and do understand that, Colorado may not have the same rules that California does with the emergency implementations across the board. So definitely share the information, but definitely look at the information, and you got to package it back for yourself in your own region.
And one of the places for urologists to share that information is on the Thriving Urology Practice Facebook group, and it's free. So consider joining. Let's see, what else? Dr. Nima from Alaska asks, do you have to have video or audio only is sufficient? If audio is sufficient, then how about just a phone call? So hopefully we'll cover that in just a minute. Susan Cruz says the insurance systems are not that sophisticated. So that, yeah, well, she would know for sure. She's definitely got a lot of experience there, having been a former employee at the American Urologic Association. Joe Hughes says, sounds like a bit of a hot mess. Definitely anything with insurance and Medicare is definitely messy. Let's go into the three different types of telemedicine or televisits that we have. And those are, number one, telemedicine, and secondly, telehealth, and then teleservices. Now, telemedicine has a strict type of a Medicare definition. So, Mark, if you don't mind covering that real quick.
Sure. So telehealth and telemedicine, so telemedicine being first, is really defined by Medicare and by the American Telemedicine Association, or the ATA. And they have a great deal of information on their website as well. If you want to look at some of that, that's there. But telemedicine requires synchronous audio-visual interaction. So that does require live, basically what you and I are doing. We've got to be able to interact on video and audio and exchange data. So that's where telemedicine falls. Stepping then down to telehealth, that's where you can have asynchronous data transmission. So that you can do over the phone. And there are different coverage rules around telehealth versus telemedicine. So you want to understand the differences between the two and the coverages between the two. And then, of course, we're going to watch and see what gets waived or what doesn't get waived as we deal with this particular crisis.
When it comes to telemedicine, Medicare has very strict requirements. You have to be in a healthcare provider shortage area, and the patient has to be at a specific originating site, and then the provider has to be in a distant site that is designated by Medicare. So the rules are pretty stringent. What about Medicare Disadvantage plans?
So actually, last year they passed a law that allowed the Medicare Advantage plans to actually waive the Medicare requirements for telemedicine for originating site. And really, that it's more about the patient than the provider. By the way, that the physician has to have the capability to do audiovisual. The patient has to be in a Medicare approved facility in a health professional shortage area. So they took that requirement away from the Medicare Advantage plans because by law they could navigate that, whereas Medicare actually by law is required to actually implement telemedicine that way. So the Medicare Advantage plans have been very actively soliciting primary care to push telemedicine further into the mainstream, mainly to cover the access problem. And this is just going to push it much more quickly.
Yeah, hopefully it'll be the patients can initiate that contact, if you will, from home instead of having a designated originating site, because that's the whole purpose, is to make it easier for the patient.
Right. So that's where the telehealth comes in, where you can look at phone calls or actually even web portal based services that are patient originated within Medicare. So that's kind of that workaround that they found, and that's where telehealth sits within Medicare right now.
And the telemedicine codes, I think a lot of them have to be patient initiated, right?
So generally, yes. Now that's the way all of that was designed. Your G206 codes and your N or your 99421 series of codes and your G2010 and G2012 are all really centered around patient prompted information or patients seeking care. Now, one of the things that they really did do, and actually CMS is backing this up, the messaging that they have right now is encouraging patients to first go to the patient's physician or to the physician's portal to potentially initiate things, or to call the office to initiate requests for a virtual visit. And they really kind of said flat out that if you want to encourage your patients to do that, you can do that. And I think we're going to see as we move forward how much we can really facilitate that. We've talked to a couple of different groups with some great ideas. When you have the message reminder, or as a general broadcast email to your patients, definitely on your website, put a COVID-19 response on there that says, if you are interested in a remote visit or a virtual visit instead of a face-to-face visit, feel free to call our office and get that scheduled, and let us know if you're not going to show up for your existing appointment. So there are messaging ways that you can do to really start talking to the patients, and these are traditional Medicare patients, about the options that they have, even under Medicare, with those patient-initiated visits through the portal or via phone.
It's basically you're kind of skirting or try to follow the letter of the law as much as you can by encouraging the patients to initiate that contact, because all of these codes, the G201, 210, 99421 through 3, these codes are supposed to be patient initiated, and a lot of people forget that when they read the guidelines.
Yep, that's very true, and it is. And I because the feds and CMS directly has encouraged people to make sure that patients are aware of this. I feel a little better about, you say it, label it as kind of skirting the intention. Ultimately what they're trying to do is find a way to essentially allow healthcare to continue to be delivered within the existing guidelines and the existing infrastructure. So I appreciate that.
That is, yeah. Well, patient. I guess when patient initiates the conversation or the contact, I guess the providers, physicians, APPs can then schedule the patient for that particular
absolutely.
telemedicine. Yeah. So, I mean, how do
Yes.
you like?
You don't have to. You're saying I think you're saying that the doc doesn't have to sit there on the phone and be the operator and wait for calls to come
Exactly,
in.
exactly.
And no, that's not the way it has to be.
And again, like you said multiple times at previous seminars, documenting that phone call that the patient initiated will probably cover the practice when it comes to audits.
Yes, it should. I mean, we haven't had any audits done yet, but I mean, we are following the letter of the law, but in this case now the spirit of the revised issues related to increasing that access.
Okay, so I know the first thing when people ask me about coverage and things like that, I think of number one. So we're talking about telemedicine. Number one, who is the payer? We've been talking about Medicare and their coverage policies, which kind of trickles down to the private payers. But everyone needs to keep in mind that private payers have their own rules, and you have to follow their policies. When it comes to telemedicine in general, what are some of the codes that we should be thinking about when it comes to place of service and then maybe modifiers, Mark?
Okay, so so once you can find out, so I mean, obviously, you see if these telemedicine or the telehealth visits and codes are covered by your payer. But I would start knocking down my payers based on volume to my practice and finding out what's covered and what's not. But the reality is, you're really talking about a fairly small group of codes that are billed for telehealth. You've got new patient visits, probably a 202 or a 203. Because you're not going to be able to really probably do a good quality comprehensive physical exam because the requirements are still the same, whether you do it remotely or not, which is where that visual is kind of required to deal with new patients. I think it's going to be hard to navigate around that for new patients. So a 202 or a 203. And then for your established patient visits, you're probably talking a 212, a 213, or a 214. Just like in your office, there aren't many 215s that are there unless you're spending the time. It's only 2 out of 3 in the office, though. Remember, history, physical exam, and medical decision-making are 3 components, or you can bill based on time. All those things apply just the same, and the documentation still applies as if you did it in the office. So you are going to have to do some of it remotely. Now, we definitely talked to a couple groups about, can you use your MAs or your staff to help collect some of the information that you need for the history? Yeah, those requirements are the same as they are in the office. So if you want to pre-screen and get your patient's history loaded up with a conversation with your MA on the phone, that may be doable before you actually have the virtual video visit with the physician. So I think those are the things that you can look at as the main codes that are there, in addition to the codes we talked about with kind of the telehealth side. And then for Medicare, all you have to do is make the place of service 02 or 02 instead of 11. 11 is place of service office, 02 is place of service telemedicine. So that's as simple as it goes. Now with Medicare Advantage plans, most of them will follow that. So a 02 with your 992 codes will be fine. Some of your private payers are going to look for a 02 place of service and a modifier. The CPT modifier, as you mentioned previously, is 95, so -95. And the Medicare original modifier was GT. So that's the other one that you can append with some of your payers. I think most of them now are taking 95 or following Medicare with the 02, but there may be a few holdouts with the GT.
Perfect. Dr. Tess says they are planning to start telemedicine visits this week. And he said he imagines that the patients using it for the first time may need a little extra effort to figure out how to connect and all that good stuff. And some might be late to their scheduled appointment times. Do those who use it usually have their MAs set up the connection? And that's exactly what you said, to have the MAs collect it, not only set up the connection, but also collect the preliminary data as if the patient is physically in the office. And I think Teddy Stevens says they run it as just as if the patient was in the office. They check-in calls. Oh, the check-in person calls the patient, the medical assistant updates the chart, and then the physician does his part. Dr. Hayeri says he thinks the easiest way to start telehealth and telemedicine is to consider doing post-op follow-ups. But we're talking about in COVID-19, we're not going to have a lot of follow-up, post-op follow-ups. We're talking about new patients and maybe established patients who may be experiencing symptoms or who simply don't want to come in to the office. Okay, so we covered telemedicine, kind of telehealth. So, and Mark, you said the 9920X and 9921X E&M services provided by a qualified healthcare professional still require all the usual E&M components to be satisfied in order for the provider to bill. So we can, I'll reiterate, you can bill by that method, which is by component, or you can bill based on time. And as we discussed at our previous seminars, billing based on time may not be the most efficient way for you to do coding and billing, but that is up to you, and you're going to have to decide how to do that most efficiently. Let's go over briefly some of the other codes that are telemedicine related. You mentioned G2010 and 2012. Those are more telehealth services, and they do not require synchronized video and audio.
That's correct. So the G2012 is the virtual check-in visit. So that visit really is something that if the patient initiates a request for services and you can solve their problem without a video visit or an in-person visit, then you can charge the G2012. The average payment for the Medicare national payment for that is about $15. And the patient will get a copay. They do need to know that they're going to get a copay, and but across the board, that allows you to treat those visits, and even if you're not in an emergency area and you don't have video, so that's available to you. The G2010 is about visual images and data sent to you that you can then call the patient back on. So that would be if maybe the patient had an X-ray and they wanted you to take a look at something before they had a procedure, or maybe they want to send it to you, decide if they absolutely need to come in, if this is going to be elective or not, or can be handled with meds or not. So those callbacks, again, by the provider, that one pays about $12. And then your 994, 21, 22, and 23 are time-based, but they're designed really to deal with the interaction that probably is going to occur if you're dealing with a patient through the patient portal. So if a patient were to ping you for some information, it may be that your MA or your PA reads the messaging to you, and let's just say the MA does it. Their time actually doesn't count in all of this when billing for the 99421, but your time of making decisions and directing care across the board as to what should be said and doing all of that, it's kind of like working with a scribe. Your time does count. And so what you want to document in the medical record is kind of what was said, and then how much time it took you to do that. And then if you actually see the patient come back with clarifying questions and you ping them again, you add it to that visit throughout the week. And then, the time breakdowns for each of those codes are there. And I have not memorized those off the top of my head, and I don't have them with me, but you can see where those times are. And those payments are a little bit higher in the 30, 40, 50 range. So you do want to look at those and check AUA Coding Today for descriptions and pricing.
Okay, and that's AUAcodingtoday.com for those who are interested. I will have a table at the very end that describes what are the codes and what are some of the brief descriptions of the codes. So in essence, so far, there are new patient codes that you could use for telemedicine, 9920X, and then also established patient E&M services, 9921X, and then also for telehealth, these are asynchronous. You have G2012 and G2010. These G codes are more patient initiated, and the G2012 has a lot of requirements. The patient can't be seen within the last 7 days and blah blah blah. But those of you who are interested can look that up. G2010 is more of a store and forward type of a thing. I call them. In urology, patients may send you dick pics, and then you're going to have to make an assessment and then come up with a plan. So, in terms to simplify things, that's essentially the way I think of it when it comes to G2010. When it comes to 99421, 422, and 423, now these are digital evaluation and management service codes that we can bill for. Now these are designed for, like you said, Mark, not for medical assistance time, but for the provider, a qualified healthcare Medicare's terms, qualified healthcare professional, which are APPs and physicians, and you add up the time that you spent with the patient over the last 7 days, and depending on how much time you spent, you build the code that is appropriate. For 99421, it'll be 5 to 10 minutes. 422 will be 11 to 20, and 423 will be 21 or more minutes. Now, what if, here's the other set of codes. What if a non-qualified healthcare provider provides a digital E&M service?
Okay, so these are incident to services provided by somebody who does not have an NPI. Now, that means there's still supervision involved, but that really the primary lift was done by your staff, your MAs or your LPNs or your RNs. And you want to make sure that they practice within their license. But then essentially they mirrored some codes, the G2061, 62, and 63 really kind of matched the 994, 21, 22, and 23. Those are available. There are incident to, and they really are more about the heavy lift of the MAs or the RNs, really providing that care and maybe just doing a quick check with the provider. So that could be, that may be refills of prescriptions and things that are done through the portal that you don't want to actually move your PAs or your NPs or your MDs to actually deal in those things. So there's a little bit of gray there, if you will, as to where, when you jump in and when you don't. But, I would really focus on the times. If you as a physician start hitting that 5 minutes of direct involvement supervision, then you start looking at the 994 codes, whereas those other codes may fall on really billing for your RNs and LPNs time.
Sounds great. And also, there's been some confusion regarding the 98970 through 98972 codes. I just want to kind of clarify that because CMS has not assigned any RVUs to those codes. You should consider not using those for telemedicine codes.
Right. So I think those are status B, with means they're bundled services overall. So, and I need to double check those, but yeah, those are codes that aren't really billable across the board right now to Medicare. There may be some payers that allow for that, but I would stick more with the codes we've talked about already.
Yeah, I just want to mention that in case somebody's wondering. So, in summary, it's the typical E&M codes, the 9921 and 20X codes, and then the G2012 G2010, and then the 9942, 1, 2, and 3 codes, and then for the non-physician providers, cumulative time, it's the G2061, 62, and 63. So in essence, that's what it is. And here's a nice table, sans the typical E&M codes, as indicated above, 98970 through 98972. You should not use those because this Medicare has not assigned any RVUs. You're probably not going to be paid. And then the other codes are 99421, 422, 423, and then G2061, 62, and 63, with the 2020 work RVUs listed, as well as the non-facility and national facility payments in that nice short table. So hopefully that is helpful to everyone. When it comes to, it says 2020 work RVUs. I've said this before to you, Mark. It's amazing to me how many years you can kind of talk about the same thing over and over, and yet you still have so much to talk about. These rules are fluid, and especially when it comes to E&M, as we know, you and I know, in 2021, this is all going to change again when it comes to E&M services.
Yeah, it is, and it's going to be. Boy, I wish they were in play right now. I mean, we could do so much better.
Oh my gosh, yeah.
In all of this. So we're excited to see those changes coming through. And obviously we'll be addressing those as we prepare for life after COVID, which will be there. It is one of those things that, focus on what you've got to do now. But then when you come out the other side we've actually got a lot of good news coming down the road with E&M codes and the documentation guideline. It's going to be fun to help implement those and walk through all of that.
All right, so stay tuned for the 2021 changes, and I know the COVID-19 has kind of put a damper on a lot of seminars, and I know you have a bunch of them that is ramping up. I know one is at the end of April. I'm still planning to go in Denver so I can learn the latest when it comes to 2021 E&M codes. So hopefully all that pans out.
Yeah, we'll see. We're on hold right now, although our 50 plus CDC gathering may have put the damper on that one. We may have to do a little bit remote. So we're remote seminars, remote medicine, all of it's we may be remote for a little while, but we'll see. We'll see what lifts or doesn't on all of that. So, definitely stay tuned. And like you said, the thriving urology practice, but certainly through PRSnetwork, we're going to be putting more information out about telehealth and telemedicine and sharing information as we implement it for our clients that we bill for. In tandem with them, we're going to be learning in different states. We're going to be talking to different groups as they're rolling out strategies and implementation across the board, and we intend to share, and hopefully you will as well. So share through Thriving Urology Practice, but also feel free to share with us and contact us. So you and I work well together, and we'll push information back and forth. It's going to take a community. It's going to take a village to make it through this one.
Well, I'm pretty confident that you'll be okay at the end of April when it comes to the seminars and 50. I know the CDC has recommended that gathering of 50 or more you should consider canceling that. But I think by then we should have this much better under better control.
I hope so. I hope you're right.
All right. Well, thank you again so much. There's been so much demand on telemedicine questions and things like that people are just pinging me. So I can't tell you how much I appreciate you sharing your knowledge and experience with everyone.
We should probably do this again because tomorrow's another day, and it really is another day.
Yeah, no kidding. It's constantly evolving. So I'm so grateful that you're doing this, and I actually have to get ready to see 40 some odd patients.
Well, good luck and stay safe, all of you.
Yeah, you bet.
All right.
Thank you.
Thank you.
All right, that is it, folks. If you have any questions or comments in addition to what we addressed, please put them in the video description below. This is being streamed to Facebook Live. I will, when I have some time this at noon or this afternoon, I will put this up on YouTube. So hopefully this will benefit even more people. I will put the links to PRSnetwork, AUA Coding Today, and Thriving Urology Practice Facebook group, among others, in the video description when I get a chance. So hope you all be safe out there, and thank you so much for taking care of the patients. Those of you in the front lines, we really appreciate you. Take care. Bye-bye.